Good afternoon, and all present here. We are honored to introduce Professor Ramachandra V. Shet, a distinguished clinical optometrist who graduated from the Manipal Academy of Higher Education in 2006 to 2007 and is currently pursuing a PhD from Massachusetts University. He is presently serving as the head of the Department of Optometry at AJ Institute of Allied Health Sciences. Professor Shet she is a board member of the Optometry Council of India and also served as an ex-board of studies member and advisory committee member of Rajiv Gandhi University of Health Sciences. With extensive experience in clinical optometry and refractive surgery since 2007, he has contributed immensely to the academics, research, and student mentorship. He is a regular speaker at seminars, workshops, and also guided postgraduate ophthalmology and DNB students in both theoretical and the practical training since 2006. Professor Shed has authored several research publications in areas including tear film assessment, binocular vision, intraocular pressure variations, diabetic retinopathy imaging, visual performance. His dedication to optometry education and clinical excellence continues to inspire students and professionals across India. We warmly welcome you for the today's session, the case report session.
Thank you, Ma. It's very great things to listen the case report. I was very interested in this case. So I've gone through the cases, but let's see how interns will be participating in this case. Let's understand their opinion on these particular cases. Then we can discuss about these cases.
Yes, sir. So today's presenter, Mr. Shakti.
Yes.
Over to you, Shakti.
Shall I start my presentation? No?
Yes,
Yeah, you can start.
Is my screen visible, ma'am?
Yeah, it's visible.
Yes, it is visible.
Okay. Good evening, everyone. Myself, Sakthivel, going to present in the topic of restoring vision after ocular trauma, a surgical approach. Introduction. Ocular trauma is a major cause of preventable visual impairment worldwide. Visual loss may result from structural disruption, media opacity, inflammation, or secondary complications. Early diagnosis and timely surgical interventions are critical for optimal visual outcomes. Advances in microsurgical techniques have improved anatomical and functional recovery. A tailored surgical approach plays a key role in restoring vision after traumatic injury. The case report. A 72 years old male came with the complaints of injury and pain in the left eye 1 hour ago with a welding machine, and no other complaints was said by him. And the previous ocular history was OU history of cataract surgery since 10 years, and he is under medications for diabetic mellitus for 15 years. Family history was not contributory. Recent investigation was nil, and he is under medications only for diabetic mellitus. Ocular examinations, he is using glasses for 15 years, but he did not bought. The uncorrected visual acuity in the right eye was 6 by 36, with pinhole it was 6 by 24, and in the left eye it was HM positive. Diffraction was deferred. EOM was full, free, and painless. Pupils in the right eye it was perla and no RAPD, but in left eye it is eccentric pupils. IOP cannot be measured due to severe pain and less cooperation from the patient. The slit lamp examination showed that right eye was normal, but in the anterior chamber it was vitreous knuckle at the pupil, and in both eyes lens was pseudophakic. In left eye, the appearance was injured, swollen, superficially vertical, linear laceration in the maxillary area, conjunctiva, congestion and chemosis, cornea, surface, epithelial defect, hazy view. Anterior chamber hyphema 1 to 2 mm, IOL status was not made out, AC shallow, temporarily hazy, dispersed hemorrhages was present. Iris shape was defect, and iridodialysis from 2:30 to 5:30 clock position. Fundus red glow was seen and no other details was made out. Clinical findings and diagnosis in the left eye, trauma sequel and B scan was advised, and these are the medications advised for. The clinical investigations, this is the B scan which is taken, and this is the specular microscope reports. Follow-up 1. The patient showed good prognosis with treatment with significant healing. Vision improved to 1 by 60 from HM positive in the left eye. Follow-up 2, 1 month later, Left eye vision improved to 6/18 from 1/60 post surgery, which is glued IOL plus pupilloplasty. Follow-up 3, 2 months later, left eye, the vision remained the same as 6/18 from HM positive with no other visual complication. The patient was advised to use 4 drops of Lubrex eye drop for 1 month in both eyes. This is the post-fundus photo, post-surgery fundus photo, and OCT image. Discussion. Management depends on the type, severity, and timing of the injury. Surgical repair aim to restore ocular integrity and visual function. Early intervention reduces the risk of long-term complications. Careful intraoperative technique and postoperative monitoring are essential. Favorable visual outcomes are achievable with appropriate surgical planning and follow-up. Conclusion. Ocular trauma causes significant but potentially reversible visual loss. Timely and well-planned surgical interventions is crucial for optimal recovery. Careful perioperative management enhances anatomical and functional outcomes. With appropriate treatment, satisfactory visual restoration can be achieved.
Shakti, your presentation is done.
Yes.
Okay, so can I ask you some questions?
Yes.
Okay, so now you tell me, you have told that ocular injury, right?
Yes, sir.
So can you explain me what type of ocular injury is this?
Sir, it is a penetrating injury. Sir.
Sorry?
It is a penetrating injury.
Penetrating injury
Yes, sir.
or blunt trauma?
No, it is not a blunt trauma, sir. It is a penetrating injury.
So how do you distinguish it is a blunt trauma or penetrating injury?
The blunt trauma, the ocular surfaces disturbance is not seen, sir. But in the penetrating injury, it is seen. Like the cornea to iris is torn up, but in the blunt trauma, nothing will happen like that.
So what are the causes for blunt trauma?
Blunt trauma, it can be a blunt objects like fist, ball, like that.
Okay, so what are the causes for penetrating?
Penetrating can be sharp objects like knife, like sticks, like that.
So is it a globe injury is there here?
Here, we are not seeing any globe injuries, sir. Only cornea and iris are damaged. Like.
Exactly. So now how will you distinguish blunt trauma and penetrating injury now? How will you distinguish with the blunt injury or penetrating injury? So what is the definition of blunt injury and what is the definition of penetrating injury? So I will go with the blunt trauma because here, is there any corneal epithelial defect was there in this particular cases?
Yes, sir. Epithelial defect is seen, sir.
Exactly right. There was a hypema.
Yes, sir.
Correct. There was a
Iridodialysis.
iridodialysis. Exactly right.
Yes, sir.
So here the patient doesn't has IOL, right? Initially.
Both the eyes were pseudophakic only, sir.
Both eye pseudophakium. Okay, fine. Then there may be IOL dislocation.
Yes, sir. There is IOL dislocations. It is seen in
How did you
the
confirm that IOL dislocations?
in the OT notes, sir.
In the OT notes.
The post surgery notes says that.
Okay, how will you confirm that your clinical findings?
In the B scan, sir.
Yeah, you didn't speak about anything on the B scan and you didn't speak anything on that specular microscope. You just show the scan and you didn't interpret the scan. Can you go back to the B scan?
1 second.
Yeah. So can you see what is the happening here? As this B scan is normal or abnormal?
No, sir, it is abnormal. The lens is seen and some vitreous condensation is seen.
Exactly. There is a vitreous prolapse is there.
Yeah.
You can see in the second picture over here. I think, yeah. So there is a vitreous prolapse as well as IOL dislocations are there. Correct?
Yes, sir.
So that's what you have to interpret your results. So this is clearly indicating that it's a blunt trauma. Okay. It's not
Okay.
a penetrating injury. Because causes for blunt trauma is this. One is the corneal epithelial defect.
Okay.
Hyphema is there. Your clinical slit lamp findings says that hyphema is there. And your iridodialysis signs is there. IOL dislocation is there. Your B scan suggests that vitreous prolapse is there. Along with that, retinal damage is also there. Because anything blunt trauma, which is also causes the retinal damage. Okay, so this is your mechanism of injury now. Because of this injury, this person has undergone the blunt trauma. Now, coming back to the visual acuity, why there was initially hand movement was present?
It can be due to the hyphema or the epithelial haze.
Exactly. So one reason is that because of the hyphema as well as blunt injury, or there may be IOL dislocation. So ultimately causing the vision drop. Now, why this person has got swollen eyelid and maxillary laceration?
So due to the injury, sir, from the mission, it was a cutter mission which was hit in the eye from the vertical position.
So it's clearly says that it's a blunt injury now. See, you have to understand case by case, understanding each and every signs, symptoms, everything. Okay, now here the swollen eyelid was there, maxillary laceration were there. How will you rule out? What are the rule out you have to do for this particular case? What you have to rule out? What
no globe injury was seen in this case.
Exactly. There was no globe injury. There was no orbital injury. Here, one thing you missed is that you have not taken any orbital imaging. We have missed out here. Okay.
Okay.
So when we are talking about to understand about penetrating as well as blunt injury, one more imaging technique is required to understand that whether it's an orbital fracture or globe fracture, because your swollen eyelid is one of the symptoms. Correct? Go to your slit lamp finding. It is there. Your slit lamp finding suggests that
yes,
there was a vertically linear laceration in maxillary area. Swollen superficial vertically linear laceration. So you have to rule out about one thing is that whether it's an orbital fracture or globe fracture. Here there is a doctor has not done that. I don't know whether it is done or not, but this has to be ruled out, because without ruling out, we cannot tell that the significance of the further understanding about the cases. Now, one more, your conjunctiva. So, what signs you see?
There's congestion and chemosis.
So, what are the causes for that?
Trauma is the cause for the congestion.
So, causes is the trauma. Yeah, one cause is the trauma. Anything else? You're right.
Neovascularization.
Okay. I will not go with the neovascularization because chemosis. You have written chemosis and congestion, conjunctival edema. So what are the causes for that? Trauma is correct, you are right. Anything other causes can causes the chemosis and congestion.
Inflammation, sir. Inflammations,
Inflammation,
irritations.
very good. So inflammation, trauma, scleral injury. Okay, any scleral injury will causes the chemosis.
Yes.
Okay, so you have to rule out that. So the possible rule out is the trauma and inflammation. Okay, scleral injury were not there because B scan is not suggesting anything. Okay. Now
Okay,
coming back to the cornea now, there was a superficial epithelial defect. What could be the cause? So it's a direct impact
yes, sir.
that whatever the melting machine directly impacting the cornea. That's what the you have epithelial defect. Because of epithelial defect, what was the sign? What was the symptoms patient was telling? What are the symptoms in your case history? It is telling this person has got pain.
Yes, sir. More pain, foreign body sensation, and photophobia
Yes.
are much for.
Photophobia and foreign body or watering.
Yes.
These were the causes for you to get the epithelial defect. Okay. Now coming back to your anterior chamber, there was a hyphema.
Yes, sir.
Correct. What are the causes?
First cause is trauma.
Okay. It's very, very important finding in your assessment.
Inflammations may also cause.
Exactly. So because
Hyphema.
ciliary blood vessel ooze this hyphema. So you have to little bit anatomy you have to understand.
Okay.
Okay. So which will causes the one important things you are not measure the IOP, right?
Yes, sir.
So why you think that you didn't measure the IOP here? Why the doctors has not measured the IOP? There is a possibility of whenever there is a hyphema, there is a possibility of having high intraocular pressure.
Okay.
So there will be a corneal blood staining. Okay, high risk factor for this particular thing, this one. So you have to be very, very important. In this case, what management they have given for to reduce the hyphema? Is they prescribe any management? Have they prescribed any drugs for these patients?
Comide was given, sir. Cycloplegics.
Very good. Cycloplegic drops has been given, right?
Yes, sir.
Anything else? To reduce the IOP, is there any drops they have given? To reduce the IOP, have they prescribed any drops? Can you see that COMPU, 1% eye
Yes, sir.
drop?
Yes, sir.
So what is that drop? So that's the name, but what is the content of that?
It's lubricant, sir.
No, it's not lubricant. It is a timolol. They are not prescribed any lubricating. They have prescribed steroids. They have prescribed cycloplegic drops. And they also prescribe anti-inflammatory drops. So you have to go everything, okay, why it is, because it is connected with your case.
Sure, sir.
Okay, so you have to understand why they have given, what was the reason they have given. So senzopred, it is the steroids actually. Okay, so to reduce the inflammation, they have given that. Homide is again inflammation, and Pompu, it is a to lower the IOP, timolol. Okay, basically its content is timolol. So that is the reason this particular drops has given. Okay, now my question is why there is AC was shallow temporarily. Why you think that AC was very shallow? Again, you can go to the your slit lamp fine, it is there. What was a possible reason? It is written AC shallow temporarily. What is the possible reason for the AC shallow? Any
Can
idea?
be due to the high FEMA, sir.
No, it is because of one major reason is that your B scan suggested the dislocation of IOLs. Okay, IOL dislocation is there. That's a reason it is a temporary shallow. Okay, and there may be a ciliary body detachment. Maybe, I'm not sure. I have not seen the case. That's what I am understanding from anatomy. And again, have they done any angle measurement?
No,
So another reason, we have to understand the anatomy. Whenever there is a AC shallow, so we have to understand the anatomy of angle. Okay, we have to understand that. And there is a clear sign of vitreous prolapse. So that is also one of the reason you're getting the AC shallow. So it is also suggesting that it's a structural destruction, which all this finding will tell you about that it is a blunt trauma, not penetrating trauma.
okay.
Okay. So now you have one more in your iris. You said that in a right eye it is normal, but in a left eye it is defocus. Why?
Due to the trauma, the iris was separated from the base.
Okay, good. So what are the symptoms may happen because of the this particular problem? Because of the eye,
Photophobia,
very good, photophobia. That sign is there. It is suggesting that it is a problem of iris. Anything else?
monocular double vision,
Very
glare,
good.
blurred vision.
Okay, very good. Monocular diplopia, uh, cosmetic pupillary size between the two eye. Okay, these are the some of the things may complaint later may come because of the depends upon the penetrating engine. Whatever the trauma which has happened to that person. Based on that, these symptoms will be vary. Okay. Now coming back to the lens. Okay, what is glued IOL? Do you have any idea on that?
Glued IOL is a IOL which is done when the posterior capsule is very weak and the haptics are glued into the sclera.
Okay. Very good. So now my another question is that why B scan they have advice?
Due to the fundus is not seen, B scan is advised for any retinal issues like that.
Okay. What are the retinal issues you can suspect in this particular case?
Detachment can be seen, sir. Some
Very good. Retinal detachment. Anything else? Because it's already patient is having IOL, right? That's what they have suggested the B
yes,
scan.
B scan.
Correct? So
Yes.
we have to rule out so many things here. One is the retinal detachment, choroidal detachment, vitreous hemorrhage, posterior globe rupture. Okay, and anyway, the lens and IOL position. Basically, we want to know how that IOL is dislocated in the globe. That's the reason that they have suggested you. They have done the V scan. Okay. Uh, Now I'm coming to the medical management. So we already discussed that. What are the medical management they have given?
SenseMox drops, homemade drops, SenseSpread, and Compo 1% drops.
Okay, that's fine. Yeah, we already discussed about that. Now coming back to the surgical management, go to the next slide. I think you have done. They have after that. Yeah, they have done the surgery, right?
Yes, sir.
So they have done the glued IOL plus pupilloplasty. What is pupilloplasty?
Pupilloplasty is a surgery to reconstruct the pupils.
Very good. So reconstruct the pupil. So why it has been reconstructing? What is the reason?
To repair the shape, the iridodialysis is seen, so pupilloplasty is done.
Very good. So now coming to the question, now we have to understand visual outcome. So first day follow-up, you see that, and second day follow-up, it has drastically improved. Third follow-up, 2 months after that, it is so much difference in the vision. This one, why that is
Yes.
happening? What is the improvement? Why that is suddenly after 1 month, one first follow-up, it is not improved. Second follow-up, it is improved so much. Third follow-up, it is much more better. After third
Due
follow-up,
to
it was
due to
stable.
the triple P, the
What
visual
was
acuity
the
was improved.
why it has taken 3 months to stabilize? Something is bad here, something is happening here, or something is supposed to be happened here.
It can be due to the healing of cornea.
Okay. What you have to understand that if it is okay, you said repair of cornea. How much time it is required to heal the cornea? Any injury of cornea, how much time is required? Because it's an epithelial defect, right? So it's
Yes, sir.
any epithelial defect. What is the pathophysiology of epithelial defect? You ought to understand that. How much time interval is required to cornea heal if it's an epithelial defect?
Its epithelium, it can heal up to 6 to 10 days, sir.
6 to
10 days.
10 days. Now, just see your follow-up. First week, 1 month, and 3 months. But after 3 months, it is stabilized. Now, what you are expecting from this particular case? You said 6 to 10 days, but literature says something different. Now, why you think that it is 3 months only it is stabilized? What is the things you have to understand here? It is clearly understood that this person's retina is intact. Okay. It is not only the other, because if it is retina was not intact, so your vision would have came back immediately after the surgery.
Okay.
Okay. So that's what we have to understand. It took longer period of the time. Because of the one is the retina was very intact. That's what I can understand from the follow. Okay. And there is a anterior segment reconstruction because pupil is, they have done the changes to become stabilized, that it took longer period of the time. Okay, so that's what we can suspect from this particular follow-up visit. So here the retina was very intact. There is no optic nerve damage basically, but still
Yes.
retina was intact. Still, we can furtherly improve in this case if you closely work on this patient. Okay, closely watch and see what is happening. Again, you can after 6 months follow-up, it may be some drastic changes may present. Okay, so you have to see that. So they have done a lot of things for this patient. What are the possible complication can happen in this case if this surgery was wrong? Or this person is not turned out in your OPD? You have to understand in all aspects, all the corners. We have to understand that. That's what we can learn better in our field. So very important discussion, because this is one important discussion. Most of the time we don't do it. What are the early complication can happen in this patient? Any idea? Yes, Satish, do you have any idea?
Increase in the IOP, sir.
Very good. So that's ultimately you're making the patient glaucoma,
Yes, sir.
correct? So that's one of the complication. Anything else?
Tiny K formation.
Very good. Because of inflammation, may possibility of endophthalmitis,
Okay.
correct?
Yes, sir.
Possibility of corneal edema. Long-term patient may have corneal edema because epithelium rupture. Okay, what could be the late complication? What are the possibility of late complication? Early complication, we understood. What could be the late complication if you're not treated, if you're left it like that? What could be the late complications?
Optic nerve damage due to the intraocular pressure.
Oh, yeah, you can say that secondary glaucoma due to rise intraocular pressure, and it is not treated and it is left like that. So there will be a possibility of the secondary glaucoma because we are not done any management. Okay, so what are the possibilities? Cystoid macular degeneration, as I just now I told you, because again, pathophysiology, you have to understand the pathophysiology. There may be possibility of the cystoid because this case will suggest you there is an intact of retina. So that's what we have to think about the cystoid macular degeneration. Okay, and there may be as already we have seen that IOL dislocation that may cause so many problems. Okay, so these are some of the late complication can happen. Okay, now my question is, this patient is a diabetic since 15 years, right?
Yes, sir.
So what are the possibility of these patients responding to the treatment?
Slow healing can be seen.
Very good. So whenever there is a diabetics, there may be a wound healing problem will be there. Correct?
Yes, sir.
Infection, chances of getting infection, repeated infections are more. Okay. And corneal healing will be takes longer period of the time. That is also you may having this follow-up visit is also telling. Okay. And there is a high chance of macular edema. 99% people will develop macular edema because of the diabetic problems. Okay, so that is also possibility. Okay, now there are a lot of discussion here. It's required here. So what could be the prognostic factors which is very important in this case? So what do you think? As that person, because he has turned to your OPD after 1 hour of injury, right?
Yes, sir.
So that is the good time he has come to the OPD, and that's what it is good recovery has happened. If this person is going back to so many clinics or so many optometrists or so many, the person is not well versed with the diagnosis, so your prognosis is also getting affected over there, right?
Yes, sir.
And next is the extent of hyphema. So here you didn't measure the amount of hyphema, which is again which I feel it is very important you to measure the whenever you are documenting the hyphema.
So it's 1 to 2 mm it's measured.
So 1 to 2 mm is how much depth? So what did you understand 1 to 2 mm?
Till the lower part of pupil.
Okay, till the now why this person has got blurred vision? That's my question again. So what do you think about that fact about what is that? Why we have to discuss here about hyphemia and blurred vision, all those factors? Now, what is the age of the patient here?
72 years.
72 year, right?
Yes.
Don't you think that it's one of the important factor for prognosis?
Yes, sir.
And this patient is 15 years diabetics. Is it a controlled diabetics or non-controlled diabetics? That part is also missing in your case history. You written that he is taking medication, but it is a controlled diabetics or non-controlled diabetics? How will you support your documentation about this case?
Shakti, are you trying to answer?
Yeah, I think he is not answering, I think. Okay, no problem. Okay, so basically age and diabetics is also matters here for prognosis. Okay, that is also, he is not documented that in his case. So whether the patient is uncontrolled diabetics or non-controlled diabetics. So that part is missing here. That's what we are not able to understand furtherly why what is happening. When we're talking about evidence-based practice, that is also very, very important to document about that. Whether it's because of the diabetics or not because of the diabetic, we are not getting any picture on that. Okay. Now my question is to, so because this person visual recovery was very good, it's because of the early treatment, no retinal damage further, and successful surgery. Again, we should back the doctor because he has done the very successful surgery and good follow. These are the very important supporting document for this case where the success of everything is there. Okay, but there are certain which is missing. So again, we can do better. Any questions should be asked, you can ask. You have any doubts on that, you can ask, discuss. Hope Shakti, you understood the case better.
Yes, sir. Sure.
Okay, good. Good presentation. I like this case. I
Thank you,
was
sir.
a lot of literature review on this case to understand your the case. So this is the new things optometrists are doing now. Very good. I was very happy.
Thank you, sir.
Yeah. Yes, ma'am. I think hope everybody has understood the case. If they have any doubts, they can ask the question. I am very free to answer that. Or you have any doubts, you can discuss with the Shakti also. It is good because he has seen the case. Hope nobody is asking question means that they understood everything. Yes, ma'am. I think they have understood everything. Thank you, Shakti. It's a very good case. I like the case.
Thank you, sir. Thank you.
Students, if you have any doubt, kindly post in the chat box or unmute yourself and ask the questions. Okay. Shakti, it was a great presentation. I think you
Thank you,
concise
ma'am.
and you minimize and you speak little while presenting the cases. But of course, Sir provoked and over the provoking questions, you answered very well.
Thank you, ma'am.
Thank you, Shakti. It was a very good case. I do.
Thank you. Thank you so much, sir.
So keep going on this way so that you learn a lot.
Sure, sir.
It will be helpful to you also.
Yes, sir. Sure.
Okay.
Thank you, Shakti, and thank you so much, sir. Thank you for sharing a lot of clinical inputs and clinical aspect, covering all the clinical aspects, sir.
Thank you, madam. Thank you for the opportunity to discuss with the student interns. I like that. So interns should come up with this kind of the cases. It is very good to interact as well as discuss a lot of knowledge. So that will help for them.
Yes,
Hopefully,
sir.
we will do
Sure,
the
sir.
same.
And of course, it is a lot of like a question and answer session. And it was like thought provoking, that is, and stimulating questions you were asking. Of course,
Yeah.
it will be like further they will be like keep on searching the questions and they will be learning a lot.
Definitely, because as this kind of the cases comes, it is very good to have discussion more. Because as an optometrist, we don't follow certain things and in our guideline. So that's what we miss certain things in our findings. Later, we want to know also it is very difficult. It could be one good writing case study. It's a good case study also. Shakti, you can work on that. Okay. So you can
Sure,
write
sir.
about
Sure.
on that because it is a good study to input work and how you have to come with a diagnosis. So one important thing is that your diagnosis was not accurate in the early because you didn't understand this is how you have to understand that what was right, what was not right. When you differentiating, then only you can understand that.
Okay, sir. Okay.
Okay. Thank you. Thank you.
Thank you, sir. Thank you so much for your valuable time, sir.
Yes. Thank you.
And this will be telecasted in the live as well as in the recorded session in YouTube and the Instagram as well. And please do watch it.
Okay. Thank you.
Thank you, sir.